My name is Dr. Paul Kent. I'm the medical director for FibroFighters. Our foundation is devoted to learning more about fibrolamellar carcinoma. Today, it is my privilege to interview Dr. Thomas Kim at Rush, a radiation oncologist. Welcome, Dr. Kim.
Thank you for having me.
So, Tom, Dr. Kim, what is it have you learned in the last few years as we have started to see more and more fibrolamellar carcinoma patients?
Through the FibroFighter Foundation, we've had an opportunity to treat a lot of patients with fibrolamellar cancers. During this time, we've realized that a lot of fibrolamellar carcinomas are sensitive to radiation therapy, and that we're able to, provide really good control and in other cases, even curative sort of approaches with the role of radiation therapy.
That's great. Thank you. Can you tell us a little bit about some of the different types of radiation? I hear a lot of, alphabet soup and IMRT and protons and SBRT. How do you explain this to people?
Yeah, so I actually like to describe the radiation therapy like a flashlight. And so it only goes to areas that we're directing this focused beam of radiation, which are usually high-powered X-rays, but there are other types of radiation, such as electrons or proton therapy as well. And these are just other ways that we can treat fibrolamellar cancers. The most sort of common type of radiation technique we use is something called 3D conformal radiation. What that means is we're just trying to be, very conformal, trying to spare the radiation from going to unnecessary areas. That way we can minimize a lot of any side effects that might occur while still achieving really good control and cures in some of our patients. There are some other sort of iterations of that sort of technique. One of those, as you had mentioned, is IMRT, which stands for intensity modulated radiation therapy. That's a technique where we're able to bend the radiation around certain structures, to stay away from other areas of the liver, for example, which don't have cancer in them, and we want to be as sparing as possible. Another technique is called SBRT, or stereotactic body radiation therapy. In that situation, we're using very high doses of very concentrated radiation over usually between 1 and 5 treatments of radiation to kind of minimize, in one way, sort of the back and forth that might be involved with radiation, but also by using these high doses of radiation, we can really ablate these tumors.
Thank you. Now, as you know, and we all know, it's often confused with hepatocellular carcinoma. How do you approach a patient with fibrolamellar carcinoma and a tumor that is a good candidate for radiation compared to HCC?
So, fibrolamellar carcinomas behave a little differently from traditional hepatocellular carcinomas. We know that from our experience. And, we work in a multidisciplinary fashion, making sure that, systemic therapy is on board. We also work very closely with the surgeons, looking for sort of opportunities for us to sort of kind of eradicate the disease as much as possible. In trying to do that, we can use what we call like a neoadjuvant approach of radiation therapy. So we're trying to perhaps minimize or decrease the burden of the cancer so that maybe it can be resected. In other situations, we're using radiation therapy as kind of a definitive way to cure the cancer that's there, ablate it, and that will be sort of with curative intent. And then another way we might be able to use it is in settings where perhaps there was some disease that was left behind at a margin, or something was very close to a edge of the tumor, and we want to kind of sterilize that area to make sure that nothing sort of recurs. And then I guess finally it would be in what we call a palliative setting. So if there are situations where patients are more advanced and the cancer is causing, let's say, some compression or some narrowing of the airways, or there's spots that are painful, we can kind of use radiation sometimes to provide some relief or improvement in their quality of life for a lot of our patients.
Thank you. And I noticed in the abstract and soon to be paper on radiation and fibrolamellar, a fair number of those patients with palliative doses, even they didn't have recurrences. So sometimes those more modest doses can work. Is that correct?
Yeah, it seems like, from a lot of the experience that we've gathered over the, I don't know, last several years or more, that it really seems to be sensitive to radiation therapy, external beam radiation therapy, and even relatively what we would consider moderate doses of radiation are enough to, get rid of the tumor entirely, or at least provide a, durable control, I would say. So it was actually kind of enlightening for us,
Yeah.
during that research.
Thank you. And that's a common thing we hear and a misconception, I think, that I see written even that says fibrolamellar is not radiosensitive. But in our experience, which is larger than anyone else's, we found that it has been.
Mm.
Well, I have Tom Stockwell here. He is the founder of FibroFighters, but also a parent, and his son Robert had radiation. Tom, would you like to tell us a little bit about your experience with radiation? This was before anyone else was really trying it. Is that correct, Tom?
Yeah, pretty much, Paul. I think part of it was a lot of folks thought, well, there wasn't really a lot of benefit in doing it. I know we've seen some patients over the last 20 years or so having spot, radiation treatment, but for Robert, he ended up having a tumor. It was a 6 centimeter tumor in the center of his head, along with a small 1 centimeter tumor in his masseter muscle, which is part of his jaw. And it was very difficult. What do you do? It hadn't broken the brain barrier, but we ended up getting a wonderful radiation oncologist at UCLA who mapped it beautifully and gave it the zapping, right? And it turned out that it killed the tumor, and not only killed it, but it was a lasting effect. So what we were finding is those were all necrotic cells, and it never did come back, which was amazing. He was able to chew, he was able to do everything normally, and before that, it was not only painful, but he was having a hard time eating. And after that therapy, he went on, because I know anytime you get any type of tumor in your head, you're of course worried that it's going to go into your brain. And that was a concern. But it was a wonderful treatment. It worked extremely well. And it's one of the reasons that we had a good idea that it might be worth, definitely trying for our fibrolamellar community.
Tom, what's the abscopal effect? Oh, I'm sorry. Both people is named Tom. I'm sorry. Dr. Kim, what is the abscopal effect?
So the abscopal effect is it's what we think is there's got to be some sort of immunologic response, we think. And it's very hard to sort of run a prospective study to really measure this. Especially at a clinical level, or I suppose at a molecular level. But what the abscopal effect is trying to achieve, or what we think is achieving, is that by treating one area of this fibrolamellar carcinoma, it may release antigens into the body, perhaps that immunizes the patient to the fibrolamellar carcinoma, and that will help the body's own immune system be able to, get rid of any other tumors that may be in the body. And so, it's a very interesting concept, which we've sort of seen in some situations, and which I think, can be something of a future sort of research interest. One of the ways that radiation works in many ways to try and kill cancer cells. One of the ways is by inducing damage to the DNA and the replication of the cancer cells. Another way is by actually destroying the cell membranes and the cells themselves, which may be involved in some of that abscopal effect. And so some combination there. So, it's an interesting idea. I think that there's definitely some interest in the community in other areas too, but I think it's something that we hope that we can achieve or at least kind of observe in our population of patients.
Thank you. That makes sense. I have definitely heard people say, if possible, get a dose of immunotherapy, or if you're on immunotherapy before radiation, that may give you a better chance of getting that abscopal effect. I have one more question that comes up. It's one of these things that confuse people a lot. Here it is. We have an interventional radiologist and they use radiation, and you're a radiation oncologist and they use radiation. You kind of sound like the same person, but you're not.
Yeah, we get that a lot.
Yeah, I know you did.
Right.
Yes.
So I would say that the biggest differences are that radiation therapy or radiation oncologists, which is what I am, we typically use sort of non-invasive techniques. And so, we are delivering the therapy without having to kind of, cut or do any incision. So it's painless. You don't feel anything. There's no radiation that stays inside your body. And so these are some of the things that as a radiation oncologist, we typically do. And interventional radiologists, what they're able to do is they may deliver, for example, like Y90 directly through the vessels into a tumor. And so that's kind of how they do it. And then we have a different way. We just come from the outside in. But I would say we are sort of cousins. And then we all used to be part of radiology at some point, and we're all boarded by the American Board of Radiology. So, we all are using the same sort of concepts, I would say. Yeah, maybe we're delivering it differently, but the same concept is there. Yeah.
Do you treat children and adults, Thomas? Dr. Kim?
Yes, that's right. Yeah, both children and adults.
Great. Tom, Tom Stockwell, do you have questions for Dr. Kim?
No, I think we covered it all. I think with the abscopal effect and with therapy, I guess maybe one question would be, can a patient remain on their current regimen when they're thinking or coming up to a procedure with you, or is there a cutoff point? That's one I think that gets asked quite a bit too.
Yeah, so we realize, how important the systemic therapy is, especially sometimes when the disease has advanced quite a bit. One of the advantages of doing external beam radiation therapy, because it's a non-invasive procedure, we don't have to hold certain chemotherapies or products that may cause bleeding risk or something like that, for example. What I like to try and do is interdigitate the external beam radiation therapy in between cycles of systemic therapy, so that we try to minimize as much as possible the downtime off of systemic therapy. And so that's kind of the balance that we try to achieve. And we're able to do that.
That's fantastic. What a great asset you've been for the community, for our fibrolamellar patients, because this has been, I think, underserved with regards to not only radiation oncology, but also interventional radiology. And it's things that we're finding has a real place in the treatment of this cancer. So we appreciate you very much, Dr. Kim.
You're welcome.
Yes, we do. Thank you very much.
Thank you for having me. Appreciate it.